Okay, so I'm sorry you don't get to look at dreary Seattle anymore, but you'll be able to walk outside in an hour and see it yourself. So, okay, so our other speakers have already alluded to the integration of systemic therapy and local therapy, and that's really the main point I wanted to make is to talk about how there is now more and more interplay of our systemic therapies potentially making radiation and or surgery increasingly useful in patients even with stage 4 disease where it was traditionally not thought to have much of a role. And there's also a bit more nuance in the idea of what stage 4 is. And Dr. Iyengar already mentioned this concept of oligometastatic disease. This is just a figure of a basic Kaplan-Meier curve. I think many in the audience, both here and online, have seen Kaplan-Meier curves before, but the idea being that in the horizontal axis at the bottom, you have time going from left to right, and survival, in this case overall survival, but it can be progression-free survival or something like that, is on the vertical axis from 0, where there's no one who hasn't had whatever event, death or progression, to 100% at the top. And when you see a gap between the curves, that represents a benefit of the treatment in question. This is from what we call a patient page in JAMA Oncology. I've actually brought down copies for anyone in the live audience who wants one. It's on the table of this patient page. And for people who are watching online or anyone who isn't in the room, you can just find this online by doing a search for JAMA Oncology patient page with the name of West and Dahlberg and statistics clinical trial endpoints, and you'll find this and you can download it. But it's a helpful primer just in one single page that gives an idealized sense of what we often talk about and how oncologists think about the benefits of treatments. And in particular, when we see a plateau on the curve, such as on the blue curve on top, as time goes on, that gives us a hope that we have patients who are doing well for a more sustained period of time, and in the ideal situation that may not apply to stage 4 lung cancer, but arguably may, for some patients, if you have a plateau on that where people aren't dropping anymore, it could be that people are cured and doing well over a very prolonged period of time. So you could check this out, but the reason I mention it is because there are some of these curves that I wanted to highlight, and that is really traditionally in the field of oncology, most of us have been taught that there's a binary, or essentially a binary division between localized disease and stage 4 or metastatic disease. That a cancer is either in the place it started or in the region where there's some lymph nodes in the area that are draining, or it has spread through the bloodstream to other parts of the body and can go anywhere it wants. And when I was trained 20-some years ago, my mentors frequently would say, the horse is out of the barn, and that's why there's no role for local therapy, because there's no value in locking the barn door after the horse already got out. But we have always actually recognized at least a little asterisk for a small subset of patients, and that's really the group that Dr. Iyengar mentioned, patients with oligometastatic disease, and that definition has been refined and still needs to be refined, but we've always recognized that there are some groups of patients who don't act like the traditional model of it's spread and there's no such thing as a little bit pregnant. This is that you could be a little bit metastatic, and that's the idea of oligometastatic disease. For patients with a single brain metastasis, we have known that you can do surgery to take that out, or you can do radiation, the stereotactic radiosurgery approach, to ablate that without surgery. But either of these, you can treat that one rogue spot that got away, and that may be a so-called precocious metastasis. It's not representative of a systemic effect of disease everywhere. It's just one stray bit that if you can eradicate, may be the only amount out there, a little island of it. So, and you can see that patients can do well for a long time. This is going out even years with patients, a minority, maybe 20 or 25%, doing well for years and years and years after that. And so we have always recognized that that can be the case for patients, say, with a solitary brain metastasis. And we've also seen that this similar concept can apply for patients with a solitary adrenal metastasis. This is with surgery for adrenal metastases. Occasionally radiation has been used for that. The same may apply for other areas, a liver metastasis perhaps, but it's been particularly evident for patients with a single brain metastasis or a single adrenal metastasis, and we know that these patients can do well 3 and 4 and 5 years later. I've had some in my career, and it just is a point that metastatic disease is not an absolute, and people can seemingly potentially be what we might consider as cured. So one other area that I wanted to highlight is that there is stage 4 disease that may not act in the traditional way that we think of. That is, you need to look at the actual pace that the disease is growing in and the pattern of spread. And at our tumor boards that Dr. Mehta and Dr. Vallieres and I and several others are involved in, we often will have a case where there's patients who will have some nodules of cancer or just nodules of something on their lungs that have been stable for a period of observation for 6 or 12 or more months, and there may be 1 or 2 sites that are actively growing. And I would say that the key issue is even if you biopsy some of those lesions that have been stable or have grown by a millimeter over a year or 2, they may, under a microscope, be something technically called cancer. But I would say that you can really digitally subtract or mentally subtract anything that is not changing at what is a clinically significant rate. Now, what is a clinically significant rate? That's easy. It's what I subjectively decide. I mean, it's in the eye of the beholder, but I kind of view it as if you have to squint to see anything change over scans 4 or 6 months apart, that's not that important. If it's measurable with electronic calipers and it's a millimeter in 6 months, not a big worry. You could take your chances with that in the background. And certainly we often see very indolent lesions. One of the big issues with the advances of our imaging is that we can find lots of nodules that are a couple of millimeters or 4 millimeters, and sometimes they grow a little bit, and we can obsess over that, but we need to remember what is clinically relevant. And if something would grow at that pace and not be a threat to you over 30 years, don't worry about it. And so if you see what I've shown here as represented in the orange as a growing lesion, so you may have 4 spots in your lungs, and that's technically stage 4. You can even biopsy a couple or 3 and show it's all the same process. But if only 1 is growing, you can basically treat that as an oligometastatic or an early stage disease and ignore what's in the background because it's really not behaving like a threat. And you can use the approaches of surgery or radiation or whatever is best based on the pattern of disease that you see and the location of the disease and the person in front of you, whether they are a good candidate for surgery or radiation. But we regularly recommend thoughtfully and not just reflexively surgery or radiation for one growing spot, even if there's a constellation of other nodules that are just not changing over time. And there's certainly some biologies of cancers that behave that way, that there's just one or two areas growing and everything else is either stable or growing so slowly it's not worth categorically calling it untreatable with local therapy. And this idea is also potentially amenable to sequential treatments, that you can have one lesion that you treat in 2011 and you follow things for a couple of years, and then in 2014 another one starts to grow. Ablate that. That makes sense. So this is still technically stage 4, and one of the things I'd like to discuss with the panel is whether we think of this as curative. I don't know that it has to be curative therapy. If people are living longer and better, it doesn't need to just be an all or none to make it worthwhile for people. I mean, if you change the trajectory of disease and people are living longer, that's our goal in stage 4 with our immunotherapies, our targeted therapies, our chemotherapy. We are very happy to have people live longer, even if we can't cure them forever, but that still makes it worthwhile. And another setting that comes up is this issue of oligoprogression. We have patients who may have multiple areas of disease, more than 2 or 3 or 4. We have chemotherapy that occasionally leads to very broad and long-lasting benefits, and frequently we have targeted therapies like EGFR inhibitors, ALK inhibitors, and increasingly immunotherapy with or without chemo that can lead to very good responses, even if it's not just left with 1 or 2 spots. But you may have overall great disease control even if you still see 6 of them. But if only 1 spot is growing after 18 months on a treatment, that is a great situation to think about radiation or think about surgery, that you can resect the one growing lung nodule or radiate it, or treat a solitary growing brain metastasis and not throw out the baby with the bathwater. This should actually say with ongoing systemic therapy. The systemic therapy is treating everything in the background and keeping it at bay. But then if you need to augment that with a local therapy to treat the one rogue area that's not as well controlled, you may have one area of acquired resistance developing. That is, we have initially sensitive disease and then you develop resistance, but it may in some cases grow in multiple places all at once. But if you have just 1 or 2 areas growing, that's a great way to, again, mentally subtract everything that is under control, keep your systemic therapy going for that, but turn your attention to local therapy to just take care of the one rogue area that you can't control longitudinally with the systemic treatment. So I will say that it's important to bear in mind the timing and the duration of the therapy and the benefit, because if you have just one area growing over a long period of time, that's a setting where it really makes a lot of sense to strongly consider surgery or radiation. But the more areas that are growing simultaneously, the less compelling that is, and the shorter the interval. If you have a scan and you've radiated one spot, that's great. But if 6 or 8 weeks later you get another scan and 3 new spots are growing, that is not a situation where you're going to be able to stay ahead of it at that point. And so we really need to consider all of these issues. What is the distribution of the disease in terms of number of growing lesions? What is the distribution in terms of time? The longer the interval and the more limited the disease progression over space, the better the opportunity for a local therapy like surgery or radiation or some combination. Now, what I'd say is the real value of systemic therapy here is systemic therapy has always been the cornerstone, and it still is the cornerstone for stage 4 disease, but it can change the potential utility of local therapies. Now, Dr. Iyengar has mentioned this pivotal paper by Hellman and Weschelbaum that came out over 20 years ago, 23 years ago, on the concept of oligometastatic disease. We kind of understood this outlier before that, but this really encapsulated it in a way that has changed how we think about this as a separate entity. But I will say that we always recognized that the majority of the disease was over here, that most patients with stage 4 disease, the disease was growing in many areas simultaneously, so it didn't matter that much. You couldn't keep up with it with local therapies. You needed to do a global treatment, not a local treatment. But what we've seen happen is that over the last 10, 12 years, we've had more and more therapies that lead to better control. And so you see this distribution where now we have more patients who have this, what we might call induced oligometastatic state, not just the inherent biology of the cancer, which was always a possible reason for oligometastatic because you just didn't have a big engine behind your cancer and it grew slowly. So the native behavior certainly can cause oligometastatic disease, but we can force oligometastatic disease and induce that if we have a treatment that's good enough. And we've had EGFR inhibitors for about 15, 17 years, and that has led to phenomenal results, broad responses that last a long time. We have ALK inhibitors. There's more targets and more therapies that work with them that lead to response rates that are very good. And now, as the other speakers have also alluded to, we have immunotherapies that largely work for a totally different population of patients who have the realistic potential of doing well for years and having very broad control. But unlike the typical patient with a driver mutation with a minimal or no smoking history and an adenocarcinoma, patients who respond well to immunotherapy are often smokers, current or past smokers, that are just as likely to have a squamous histology. They're just not the same demographic. So it's broadened the pool of patients out there who can potentially have a great response that lasts a long time. And so now we're kind of driving things so that we have a lot more patients who are potential candidates for a local therapy just because we have changed the biology with an effective systemic therapy on board that we didn't used to have. And so this leads to this idea of induced oligometastatic, and this is really the setting that Dr. Iyengar was speaking largely to, that you can have multiple areas of growing disease, you have a great treatment, and a lot of it goes away, but there's just 1 or 2 areas of residual disease, and whether that's growing or not, and that may be one of the areas of timing that we need to debate, you can treat that residual area or 2 with surgery or radiation or a combination and potentially change the pace of the disease that follows. And I have not been fascinated by the idea that you take that out and don't see it anymore. You could do that with Adobe Photoshop. But what to me is interesting is that if you take it out or ablate it and then it gets better, that you have a lower risk of new disease popping up elsewhere and people living longer. And so this to me is really exciting, that you actually push back the timeline of the disease. You reset the clock. Even if it doesn't mean that the cancer will never come back, if it pushes it back by 1 or 2 or 5 years, it's very valuable. Now, one of the questions that we will also need to tackle both in our panel and with research in the next few years is this because you've just taken out the residual disease that is the main resource that's going to lead to acquired resistance? And in other words, the more cancer that's visible, the higher the chance of it becoming resistant. Or is it an effect of the immune system perhaps being more on a high state of alert and vigilance and leading to what's called an abscopal effect from radiation? And that is a debated point of, how much is this the interplay between radiation and the immune system, whether the native immune system or with our immunotherapy treatments. But at the end of the day, these trials that are not large but have shown very dramatic and consistent benefits have shown that not only does it prolong the time before new lesions emerge, but patients may live longer for this, and that's quite exciting. But this is still small numbers of patients and selected patients, so I think we need to caution that it's not everybody. But I would highlight that we have more and more patients who I think are going to be attractive candidates for this. This is compared to just 2 years ago, let alone 5 or 10 years ago. Now, we always had chemotherapy with a response rate in the 25 or 30% range, but frankly, the duration of those responses is not typically as long as we would like, nor is it as deep a response. Yes, it was definitely, chemo is still active and a helper, but it's a different qualitative response than we get if we hit the cancer with something that is fundamentally driving it. And so we've had these driver mutations we've known about, EGFR and ALK and ROS1 and some others, where if you hit the target with the right targeted therapy, you get a response rate of 70 or 75 or 80% that can last for years. Single agent immunotherapy for patients with high PD-L1, which is about 28 to 30% of our patients, has a response rate nudging close to 50%. And these can be very long and great responses. It's not 80%, but it's very good. It's approaching a 50-50 chance in these patients for a great result. And now, in most of the patients who don't have a driver mutation, we are choosing between immunotherapy alone and immunotherapy combined with chemotherapy, which has a response rate of 50 to 60%, approaching 60%. And so more and more of our patients have the potential of not only have their tumors shrink, but having it shrink a lot more and for a longer period of time. Now, one issue is that I do think we need to highlight that oligo means few. And so oligometastatic applies to 1 to 3, perhaps. And as we've discussed, it could be maybe in some trials up to 5. There are a couple of trials that are going up to 10. But I think that this is a bit of the street lamp effect of, well, it's easy to get patients. We can get more patients on the trial if we broaden the eligibility. But that is the street lamp effect being, I lost my keys in the dark alley, but I'm going to look in the well-lit street because the light's better there. You know, but that's not the point. Doing the study in the wrong patients could really undermine the benefits. And that's my concerns about this. But we've also seen a self-selection where the majority of the patients enrolled on these trials have had few, typically one, metastatic site. And in fact, in the MD Anderson trial by Dr. Gomez, they call it 0 to 1 as a category. 0 being none of the metastatic sites is there, but the primary tumor is left behind. And those patients seen in some of these trials do significantly better than the patients with 2 or 3 or more. And so I am wary that just the primary being visible or one other spot is a lot better than 2, which is a lot better than 3 or 4 or 8. And so I do think that this doesn't necessarily apply well. And so the concept is, you know, it really is a lot like a game of whack-a-mole. And that's one of the ways that at least some of the medical oncologists have kind of dismissed the idea of local therapy, that you can't keep up with it. And that makes sense if you're trying to hit 4 things popping up at the same time. If we're thinking about surgery or radiation or some combination, and by the time you take out or ablate one, new things are popping up before the next scan, you're never going to keep up. But the appeal of our systemic therapies working is that this may still be the process, but it slows it down tenfold. And you can definitely still play and win at whack-a-mole if the rate of new things popping up is 1/10 of what it was before. So that is, I think, the interplay. Yeah, even if doing surgery or radiation is still a game of whack-a-mole, you can do much better with that if systemic therapy is significantly slowing down the engine and making it possible to have just 1 or 2 lesions popping up every year or 2 or 3, rather than 5 things simultaneously with every scan. Now, this is not standard of care just yet, and I think this is another thing that we need to discuss as a panel and will continue to evolve. I would not want to imply that everywhere people are getting treated, everyone should be getting all of their disease resected or ablated once after their first response. But it is something that is gaining traction and gaining mention. This is the NCCN statement, just that patients with limited site oligometastatic disease and good performance status may benefit from aggressive local therapies to the metastatic and primary sites, with clinical data suggesting the possibility of long-term survival. It's pretty tentative. It doesn't define what limited site is. It doesn't say with 1 or 2. It leaves a broad range of judgment, good performance status, aggressive local therapies. It doesn't say everyone should get SRS or stereotactic, ablative, body radiation, or surgery. But it is a reasonable thing to think about, and it doesn't say that this will cure people. I would say that we may see that some people have a survival that turns this into such a chronic disease that it may not limit survival, which would be amazing. If we could turn metastatic lung cancer into something that needs to be managed like diabetes, it may not go away, but if people live with that for years and years and years, that is certainly the next best thing to cure.